All right. This is the second video of Module 9, where we're going to talk about how nurse-led initiatives can support the quality-based reimbursement. I know I should have kept it as one video because you just couldn't click fast enough to get to this exciting topic. So here we go. So when you start looking at the fact of how's quality-based reimbursement working, we know from the last video that for my adolescent WellCare visits, I can get a 0.5% increase in my reimbursement. I also know that if I talk with my senior citizen who's over the age of 65 years old or older about advanced care planning as part of maybe a preventive exam, that I can get an additional $73.58. I also know that if I manage my diabetic patients and I make sure that all my diabetic patients at least have an A1C test done, even if their scores are under a 9 or over a 9, it doesn't matter. Just if I get that done, my practice will get another 0.5. So I can at least increase reimbursement by 1% right there. Plus I get the extra money. Plus I get the visits. So here's an opportunity for you as nurse practitioners to say, let's go into primary care offices and say, I'm going to take care of and I'm going to see all of your annual Medicare exams. I'm going to do all your welcome to Medicare visits. I'm just going to create a preventive program inside your internal medicine practice, and I'm going to take care of all of these diabetic, hypertension, or no, excuse me, all the preventive stuff, and I can just generate $193,000 based off 2,000 encounters in 1 year. I can be that preventive programming inside internal medicine. I can create a psychiatric nurse practitioner behavioral health program, and I can do substance abuse counseling with a patient in a home setting through telehealth and get paid. I can do a women's health and look at women's health conditions. I can take the diabetics, which is the next slide. I can take the diabetics in a disease registry or pain management program or patient management program and put all my diabetics together, and I'll work to manage them, make sure their diabetes is below 9, that I had the scoring. And you can see how these programs inside the bigger programs can actually generate money through quality-based reimbursement. And so in the model here, I kind of look at it as Uber. If you look at Uber, Uber is one of the country's largest transportation companies, and Uber doesn't own a car. There's no brick and mortar that they own. They don't own a car. So we can have a very large integrated practice as a nurse practitioner profession and never own the brick and mortar. Just like Uber, largest transportation company, doesn't own a vehicle, but they're getting people moved around. We can have a group practice without walls inside of a internal medicine practice, inside of a medical school, inside of a hospital that's managing these populations of people that are driving that quality-based reimbursement program. And as a profession of health nurse practitioners, we're generating that positive outcomes because we know how to do it for those physicians who are used to transaction-based, volume-based type practices. So that's just one way or one idea of practice. The disease registry patient management I touched on, which is let's go in and take care of all the hypertensive patients in the practice, and there's quality indicators and payment assessed to that. This is where I talk about the diabetes. Let's go into a pediatric allergist office or pediatric asthma pulmonary practice, and let's take care of all the pediatric patients have controlled asthma. And let's make sure they stay out of the hospital. Let's make sure they stay out of the emergency room. Let's make sure they stay controlled. And when we do those things, cha-ching, we get money for it. And if you think about it, the physician or the specialist in those settings, they don't want to see these people anyway. They want the more exciting cases. So we can work with carriers to then identify and show cost savings, and we can embrace technology to do some of this, not by seeing these people, but through virtual care or telehealth. Now, what's a virtual care? That's a new thing. 2019, part of the whole changes that are coming is we have virtual care. It's not the same as telehealth. You can only do it for established patients. But what it is, it's paying you as a nurse practitioner to virtually check in with your patients and provide a brief non-face-to-face assessment. It's pretty much how you doing? Are you taking your medications? Let's look at your blood pressures. What recordings do you have of your blood pressures? Let's talk about your weight. Let's reassess your BMI. All of these virtual check-ins that you now get paid additional revenue to for a Medicare patient. specifically. We'll see how this gets adopted in the commercial side, but for Medicare, you can get $16 to $14 by checking in on your patients. Well, isn't that part of managing a patient now? So now we're also going to get paid to manage those patients. Federally qualified health centers typically get paid on an encounter-based reimbursement. This is in addition to charge to federally qualified health centers that want it. And patients can now, or practitioners, you can get paid for remote evaluation of patient-submitted videos or recorded video. So take a picture of the rash, look at the imagery, look at a video, and when you do that, you get paid $14 to kind of virtually take care of the patient. So this is a new opportunity for revenue, and it's good patient management to integrate this in your practice. So if you're in that practice that just says, I just want to keep seeing patients, put them on the schedule, double book them on the schedule, stop. Look at this in a complete different way. Look at it as quality and engaging and connecting with your patients. Telephone calls. Everyone says, well, I never get paid for a telephone. Well, then you're silly, because you should be getting paid for telephone calls. Here's an example where Humana, as a commercial insurance carrier, pays for it. So why are you not getting paid for it? So use the telephone, use your virtual care visits, and start looking at ways you can reinvent the way you deliver healthcare. Digital healthcare. There's 12 states that enacted legislation that require private sectors, the Aetnas, the Blue Crosses, the Uniteds, to pay for telehealth services. Why are you not using them in your care delivery? New guidelines just came out for 19 that includes expanding Medicare-covered telehealth services include prolonged preventive services. So I can do preventive services and preventive care in a telehealth setting with Medicare patients in the coming year. So let's go back to our little program here I talked about where I wanted to do where I wanted to do a preventive programming where I will go in and do all your annual Medicare, Welcome Medicare employer-based programs. I'll do face-to-face, but now it appears that I can do it through Medicare, through telemedicine. Let's do it. Michigan State University survey revealed that 130 private payers were reimbursing for telehealth, with Blue Cross Blue Shield being a leading payer in this country. So it's not just a Medicare thing. So we need to embrace this and create care plans and programming and patient work, not around an episode, not around a transaction with the patient, but around a management of that patient. And then this just is imagery that shows you the telemedicine parity laws where they pay for telemedicine, and then there's no parity legislation in our great state of Florida. We have it in New Jersey. So you can see the country's moving in this direction. So it's a very good thing. Another program. As nurse practitioners, I've got these patients that have 2 or more chronic care conditions. Let me take care of them. That's what I kind of talked about in that disease registry type thing. So I'll just take care of all of those. Now, typically in the chronic care management is you document at least 20 minutes of clinical staff time directed by you as a nurse practitioner per calendar year, where you've got your nurse calling, they're following up on patients, you're making sure that they're taking their blood pressures, that we've got obesity, the nutritional diets are being taken care of, and we're doing those check-ins, and you're documenting at least 20 minutes of interaction with that patient. Well, that's great, and it's really designed around the nursing and the way the RVUs and the models were set up. It really is practice expense heavy because it's not you doing the work, it's your staff doing the work. Well, let's think about some of our solo practitioners that don't have nurses or don't have that luxury. And what if you, as the individual nurse practitioner, are the one calling and checking on your patients? Well, this coming year, we now have a new CPT code, 99491, for your personal time, where you're spending the time managing that comprehensive care plan that you established, and you're the one doing the 20 minutes of time working, talking to the patient, doing those things. Now, you can't double dip. If you're doing chronic care management and you're billing the 99490 or the 99491, you can't go back and also do virtual care billing, and you can't do telephone billing, because all of those are kind of inclusive in the work you're doing under chronic care management and billing these codes. So you can't double dip, but you can see where there's an opportunity for you to manage a patient base and take care of them. This I just threw in here. Interprofessional internet consultations are also new in 19, where you can have an interprofessional telephone or internet conversation or electronic medical record connection with a consulting physician that will provide you a written report back. The patient does have to consent because there is a cost share to the patient for this. But if you do it for the true value of the patient, this is how you get your telephone or internet telehealth type interprofessional communication with a colleague. Now, CMS is quick to point out this isn't because you're clueless and you need to call a friend to help figure out how to diagnose the patient. So it's not for your personal edification, but if it's for the true benefit of the patient, that's where this comes in. And it is a time-based service. Granted, the reimbursement rate, as you can see, is the same, but this is a way to keep that patient while they're in your office and you're taking care of them and you're being comprehensive in their care and you're going to write 19 referrals to specialists and ship them out the door. That's so old school. Get the specialist in an interprofessional telephone, internet consultation, send them the records to the EMR where he responds back to the EMR with written report, and be a little bit more innovative in your approach to the way medicine is practiced. Another way you can take a look at this, let's go back to Module 6. We talked the first step of the revenue process is, yep, you're all saying scheduling, very good for you, or you read the first line. When you look at scheduling, that's really the key into the practice. So if you have patients coming in for care gaps, where we don't have preventive exams done, that we're pulling kids or adults in for their preventive exams, or your diabetes folks need to come in to be seen, if your schedule's booked up for 4 weeks, 4 months out, that's not going to really cut it. If we think about a lot of the universities where we're getting our educations, and you look at the medical schools and you see they've got 4 months out, 3 months out, you can't get in to be seen for 4 weeks, that's not really going to work in this model. That's really not going to work in the quality-based program, because if my child is having an asthmatic issue and I'm not sure what to do and I can't get in for 2 weeks, I'm headed to the ER. So you've really got to be able to embrace and change as simple as scheduling. You cannot have your, grandmother's friend's daughter who's home for the summer sit there and do the scheduling. You just can't. You've got to get them as part of the, how are we going to impact healthcare? So we need to have open access scheduling. The example I use is I started with a practice, nurse managed, that they had a traditional model, which is the first box, where 100% of all the patients were booked. So we had, you want to be a new patient, you can come in 2 weeks from now. Or established patients, we'll try to get you in next week. Folks, no, you can't do that when we're impacting quality. So what we did is we migrated to a carve-out model where we had 50% were same-day or urgent care walk-ins, and we booked 50%. And we ultimately got to the place where 65%, what we call our advanced access model, were open, and 35% of our slots were booked. Now you can say, oh, that's so risky because what if patients don't show up? Folks, if you're doing outreach and you're calling people and you're telling them to come in, you're telling them to get in, and you're constantly on the phone saying, hey, how's your blood pressure? Let's get you in. You need to be able to see those people the day they call or the next day to truly impact healthcare and be a partner with them. Not, oh yeah, I'm a partner in your healthcare. Come see me in 2 weeks. That's not a partner. And what we did is for Molina Healthcare, that patient base, which is a Medicaid base, we moved them to the advanced access model and said, you know what, let's look at, we took the census from the emergency room 1 year ago, and we highlighted all, and we were in a remote area, so we knew that that's the only ER they can go to, and we highlighted all the patients that went through the emergency room, literally highlighted, green highlighter. Then we pulled the census from the ER the next year, and we used orange because, papers can get messed up. We used the orange highlighter. I mean, scientifically here, exact. Highlighted all of the patients that were on our roster. We showed that the number of green highlighted patients on roster 1 from last year to the orange highlighted patients on roster 2 the second year significantly dropped. Why? Because I went to advanced access modeling where 65% of our slots were open, and if a Molina patient called us and said, I'm not feeling well, get in here right now. We're going to take care of you. Don't go to the ER. Get in here. Let's get you on the phone. Let's get telemedicine in place. Let's, talk with you. Let's check on you tomorrow. I'll call you back tonight. I used my cell phone. We use technology, and we manage that population. So what do we get for doing that? Well, we sat down with Molina and said, hey, we have 2 options. Option one is you pay us 10% more in reimbursement because here's the success and the things we're doing. Or option two is when you walked in, you saw there's an ambulance sitting out front of our building. They're here to take Molina patients to the emergency room, where every patient that walks through the door, it's Molina, I'm going to say, get in the ambulance and go directly to the ER because a prudent layperson, this is an emergency. And I'm going to put everyone in an ambulance. So you either pay me 10% more for keeping them out of the ER, reducing the admissions, managing and taking care of these people, or I'm going to send them all directly to the ER, don't pass go. Yes. Now, granted, we didn't get 10%. I think we got like an 8%. So there was some negotiation. But we got an increase in reimbursement. In fact, we got paid more than the physicians as nurse practitioners because we're managing care. That's controlling quality. That's taking the time to make it work and do it right. Other options, medical home visits. We've got so many nurse practitioners going out doing medical home visits. They're embracing digital healthcare as part of that. But it's let's get in the home. Let's start seeing the patients. We have nurse practitioners that go out into the home and are taking care of patients. And if you look, 2,000 encounters a year, I'm at $162,000. That's not a bad salary. Now, granted, you've got expenses in there, but this is another area of opportunity where you can make a difference. Pre- and post-operative care. Let's think our inpatient folks. I know we got a couple folks hanging out in the hospital. So what do you do for post-operative care? I have a surgeon come in, and he's going to take the global surgery period, but he wants me as the nurse practitioner to do all the pre-operative stuff and do all the post-operative stuff. He's going to just do the operation, the intraoperative, but I'm going to be the slave and do everything on the front and back. Okay, great. If I'm an employee of that physician, what's your value? Because you're not generating revenue, but in fact you really are. Because if you notice, if I did an appendectomy, the global split on an appendectomy 44950, the preoperative is worth 9%, the postoperative is worth 19%. So of that $667 procedure, 19% of that is work you as the nurse practitioner did. The physician, the surgeon, the intraoperative surgery is only valued at 81%. So if I'm a physician, go back into my hospital where I have nurse practitioners in the hospitals, I'm a private practice guy, the hospital provides me a nurse practitioner to do my pre- and post-operative care, which we know is a kickback, and we already read several modules back about how illegal that is and how hospitals are getting in trouble, Duke University and folks. So this is how we bill and say, perfect, will you bring your patients to our hospital? My nurse practitioners who are employed by this hospital will take care of your private practice patients. However, I will be billing a preoperative care. I'm taking that 9% using a 56 modifier. I'm taking my postoperative care of that appendectomy for 10%, and I'm using a 55 modifier. And you, Dr. Private Guy, when you bill your intraoperative appendectomy, you need to apply a 54 modifier on your services, and you will get paid 81% of the 667. The other 19% is going to come to me as the advanced practice nurse group employed by the hospital. That's how you get your money and support the doctors. If you're employed and they go, God, I just don't see value for you, but you're the one doing all the pre- and post-operative, you need to look at that 44950's 19%, what the allowable is. That's the money you are generating. That's your contribution as an employee to that entity and that business piece. And there's this same formula at the bottom exists for every single CPT surgical code that exists. So you can back into what your value is. Let's stay in the hospital. Transitional care. If you have a patient admitted to the hospital, when they get discharged, and as long as you have their established relationship with you prior to discharge, you manage that patient's 30 days post-discharge, you have the ability to pull up $320,000 on 2,000 patients. So what we're looking at, and you say, well, gosh, why do people pay for this? Well, it's the cost avoidance. Medicare had set aside $600 million for this program, but they spend $17 billion on readmissions. So all they're doing is throwing good money at someone to help us reduce the $17 billion. So we get $60 million in the bucket. Go after it. Oh my gosh, there shouldn't be a hypertensive, heart failure patient, diabetic that's leaving that hospital that the physician, the attending is taking care of them. And so if you're in the practice and the docs are like, oh, I have all these discharges and I just can't manage them all, you know what? Give them all the nurse practitioners. We'll do them all day long. And for in turn, I'll get $320,000. Just pay me half of that in salary and we'll call it a day. So it's that type of forward thinking that you got to look at. Finally, some other revenue generating ideas. I'm going back to the hospitals since I know we have hospital folks. Rapid response. We have so many hospitals where, in fact, I love the one we worked on. All the rapid response were RN, registered nurses. We swapped them out, put them all in nurse practitioners, instantly became billable because every time you respond to the bedside for a rapid response, a patient that's deteriorating, an incident that occurred, a code, if God forbid, if anything like that happens, cha-ching, you're going to the bedside for a reason why they're not there. Something happened. That triggers a billable event. ICU care is time-based, so we have nurse practitioners treating patients in the hospital in the evenings. They're in the ICU. That's time-based billing revenue. Palliative care, gosh, doctors didn't like doing palliative care. We had 3 nurse practitioners in one of our facilities that all they did was all the palliative care consultations in the entire hospital. And how we built their business is we changed the bylaws to let the nursing, the floor nurses, order or call for palliative care, and you didn't have to have a doctor's order, and that just boosted. I mean, we like tripled our palliative care volume. Because if the physician has to order it, it's almost like the physician's giving up, and the family's like, well, why did this palliative care person come in? Well, the doctor ordered it. Now they're like, well, the doctor's not fighting for me. So when we let the floor nurses do that, then it was like, no, we got called in by the floor nurse, and so it became more collaborative. And then observation unit, can't be more excited about this one. A recent project is we had patients admitted to the hospital that were in ops. Well, the doctors poorly documented. We failed to get the patient's documentation to where they actually truly admitted, which is a lot more money to the hospital, and people sat on observation for 48, 72 hours, which is allowed, but they never met admission criteria because the doctor didn't document well. Well, what do we know nurse practitioners to be very, very good at? Document, document, document. So we changed the bylaws of the hospital, put nurse practitioners in the ops units, and they manage the ops patients, and their documentation, because we're not lying, but the documentation was comprehensive, complete, and accurate that allowed us to move those observation patients inpatient, which was a huge reimbursement to the hospital, paid for the nurse practitioners. So those are ways we can use APN programs to generate revenue for the entities and things. Wound care, nursing homes, gosh, we haven't even really talked about that, but there's another place. Now, I know I've kind of moved off the quality-based conversation we were at, but you can see how we can evolve from programming and quality and how we can put programs together where it's practices, it's your practices, it's practices and how you can contribute to your employers and the people you work for. School-based health centers, gosh, I could just keep going on and on and on. This is so exciting. So we are in a changing landscape. We need to commit to it. We need to know that we've got to set goals. We've got to establish how it's going to look. Population health, it's a term we all hear, but we've really got to look at defining a new strategy in the way we deliver care. I mean, you go back and you look at Module 6 and you look at the managed care contracts and you look at the credentialing and you look at all the things we had to do, but now let's look at a new strategy and how we're going to do it. I want my managed care agreement not to just be a transaction-based encounter. I want that agreement to include those incentives of the quality-based performance program. I want to be a patient-centered medical home where I get a $3 PMPM for case management. I want the strategy of managing patients, not transaction patients. And I'm going to use the technology to do all my data analytics. And I want to resolve care gaps that are identified where I've got pediatric patients that have gone 3 years and never had a wellness exam or a pediatric child wellness exam. I've got women who aren't doing breast screening. I've got mammograms being missed. We need to transform our practices from a transaction-based environment to where we have care plan oversight, where we are actually working with our patients. That's going to generate the revenue and volume. And this profession of nurse practitioners, if you can get the business accliments of all of this, understand the business pieces, which is what I hope this program really has kind of helped us with, then you should be able to look at the whole process, my roller coaster ride, know where you've got to make changes to truly make an impact in the practice. And I cannot be more excited. And I am so hopeful that this course was beneficial to you and you got what you were hoping to get out of it. And tell all your friends how wonderful it was. So just joking. Thanks so much. That's the end of Module 9. I think we have a few test questions to kind of show you made it all the way to the end with me. And I look forward to the discussion boards. That's my favorite part of the whole course. So thank you so much.